Simon.
Professor Liu, good morning.
Good morning, everybody. Good morning, Simon. Good morning, Camel. Now I show you a case for
Thank you.
staghorn renal calculi. This
Okay.
patient is a female, 47 years old. Can you see the X-ray image?
We can, but if you have a CT scan to show us, it will be even better if you have.
CT scan 可能看不到了是吧？
If we cannot, don't worry. We can see. On the
Yeah.
ultrasound also, looking
Yes.
quite similar to the X-ray picture.
Yes. For this case, I will use the ultrasound guidance and X-ray guidance together.
Gold standard.
Both standard, yeah.
Platinum.
Hi, Mr. Multi-Track Man, my dear friend. How are you?
Fine, fine, fine.
You
My
are ready
brother.
for another multi-track puncture.
Now, today I will perform multiple mini PCNL.
Multiple mini PCNL, but multiple again.
You can see the ultrasound image. This is the spleen surrounding the kidney. Can you see?
Yes.
So this is the one advantage of the ultrasound guidance. You can see the adjacent organ surrounding the kidney.
Yeah. Bowel, spleen, liver,
Yeah.
pleura, lung. Very good.
It's for this way, for puncture, you will injury the spleen.
Yes.
So I change this way, not this way. You can. This way you can see the spleen surrounding the kidney, and this way you can avoid the spleen.
Sorry, so how do you decide where to go in? Are you coming in interpole calyx or upper pole calyx?
For most cases, for staghorn calculi,
Yeah.
I often select the upper pole.
Okay.
Because I think upper pole can reach most part of the kidney.
Yeah. And are you doing a 14 French super mini PCNL?
The first thread, because the stone is very large.
Yeah.
So
Yeah.
the first thread I will select 20 French.
20 French. Okay. Okay. And 20 French with suction or without suction?
I use the multifunctional laparoscope. Use ultrasound refrigerator.
Okay. Ultrasound. Then ultrasound has a suction, right? Yeah. Okay. So, okay. And what is the length, the size of the stone, and what's the Hounslow unit? Is that the interpole or is that the upper pole where you're coming in?
Interpole.
Yeah. We love interpole puncture for super mini PCNL, 14 French, but this one you're going to do 20 French. How hard is this stone?
The CT scan is 500 to
Hounslow
600
unit.
HU.
Yeah, okay, okay, good. So do you if you want to do a multi-track PCNL, do you put the second tract second guide wire in now, or do you do the second tract later on?
I often use one by one.
One by one, yeah, okay. So, are you sometimes concerned that after doing one tract and after doing the operation, there's gas in the system, and then you cannot use ultrasound to find the second tract?
Yeah, exactly. Maybe the first tract will influence the
Second tract, yes,
second
yes,
tract. Yeah.
yes.
This stone is not clear under the ultrasound guidance. Not clear.
Yeah, not completely clear. I mean, that is one slight thing about ultrasound is that, you know, it's in a few cases the visualization is not always perfect. But it's the same
Okay.
for nice. It's the same
Can
for
you see
X-ray as well.
the
Very
the
nice.
the
Fluid coming
urine
back
come out the needle? Yeah.
beautifully, beautifully.
找他。
Is there
Well,
infection? Does the patient have infection in her previous MSU?
yeah, it is positive for
Is it-
urine culture.
So it's an infected soft staghorn stone. Yeah. Wow, that's
Can you see?
very nice.
Right.
Beautiful. You see how wonderful X-ray is? Only the occasional spot.
From the skin to the keratin system is 7 centimeter.
Okay.
Professor Liu, this is Albert. What size is your first truck?
The tract size
First truck. What will be your initial truck?
20 French.
20 French. So you will be using ultrasonic.
Yeah.
Okay.
Maybe we often perform standard PCNL use above 24 French. But if you use my laparoscope, you only use 20 French thread to perform standard PCNL.
What size is your first that dilator you use? What size was it?
20 French. Oh, the first.
Yeah.
The first is 12 French.
12 French, okay.
The second is 16.
16, yeah.
And the further is 20 French. Lost step by step. 走一下，走一下，Go。
What kind of what are you using here now? What is this?
太黑了，这个图
It's a Chinese. This is a Chinese mini PCNL.
太黑了，一张。
No suction, yeah. No suction. Okay.
OK。
Well,
这个水是多少？
we're lucky to be able to see a Chinese mini PCNL.
嗯，放一下，放回。
Do you know your ultrasound plastic is blocking the view of your hand? Can we move, please, Professor Liu?
Pardon?
The ultrasound probe and the cover is blocking your hand. We cannot see your hand because on the left hand side, the plastic sheet on the ultrasound is blocking the view.
OK OK OK. Maybe the second picture will show you my hand.
No. We're talking about right now. That ultrasound cover on the left hand side is blocking the view.
OK. I
Can
see.
you just move that ultrasound away?
哦，
But
这
this
个
is very
超声档
nice.
的。
Yeah. This yeah.
OK。
So very nice. Thank you. Thank you. So when was the first Chinese mini PCNL done in China?
The first track,
Yeah, first Chinese mini PCNL. When
Chinese
was it?
minister maybe less than 20 friends.
Yeah, and what year? What year was the first
Oh yeah,
Chinese?
1984. Since
Yeah,
1984.
yeah. It's just that you don't find it in the publication because Professor
The
Chun's
publication
boss.
is in 1992.
The first publication 1992. Yeah. Okay. Yeah. So you're putting a ultrasound suction probe into
负压太大
your nephroscope.
The negative pressure is not
Too much. Yeah.
too much. Yeah.
Yeah. And what size is your nephroscope? If your sheath is 20, what size is your nephroscope?
The level score is 17 friends.
17. Okay. So what is your irrigation pressure and what is your suction pressure?
现在灌注压多少？100 100
100
irrigation
is the
pressure.
irrigation pressure.
Yeah.
Yeah. And can you tell what kind of reading is on your suction pressure? Is it 0.4 MPa or
0.02.
0.02? Okay. All right. Yeah.
This is 导管吗？
Yeah. EMS.
The candy slat is narrow.
Sorry, Professor Liu, what is narrow?
The candy leg.
The infundibular neck, is it?
Yeah, infundibular. Yeah.
Infundibular neck, yeah. So we are lucky that we can see this technique, but I might have done a 16 French super mini, and
Yeah.
if the stone is soft, I think a 16 French super mini or even a 14 French, we can get all the stones out, Because the smaller the tract, the easier to talk. Are you nearly into the renal pelvis? Yeah, looks like you're nearly into the renal pelvis.
Yeah.
Yeah. Your retrograde catheter, is it?
Yeah, very narrow infundibular.
Yeah.
支架可能往下
Advantage of
滑
a smaller tract. Yeah.
Move the capital. Because the stone is not hard, so it is very suitable for ultrasound.
Yes.
Ultrasound lithotripsy.
Lithoclast is better for very hard stones. Ultrasound is better for softer stones.
So for different types stone, we'll use different lithotripsy.
So do you use combined ultrasound and lithoclast lithotripsy, Professor Liu?
Yeah. I sometimes put the class into the ultrasound pro.
Yeah.
Sometimes it's better for CT scan value from 1,000 to 1,000 to 1,300 HU. It's very better for combination ultrasound and little class. I think.
Yeah, we have the Swiss lithoclass master, which is combined
Yeah,
ultrasound and
if the CT scan
lithoclass.
less than 1,000, I think only use ultrasound is enough.
Mm. Good tip. Good tip.
This case is 500 to 600 HU, the hardness of the stone.
Professor Liu, I want
Yes.
to ask, you said different types of stone, you use different types of energy. So when you prefer to use the laser and when you prefer to use the pneumatic and when you prefer to use the EMS, I want to ask this question. Thank you, sir.
Okay, thank you. If the hardness of stone, the CT scan is larger than 1,300 HU, I will select helium laser. If the CT scan is less than 1,000, and I will select ultrasound lithotripsy. If for moderate hardness stone, I will select needle class. If the CT scan from 1,000 and 1,300, I will select needle class only. So for very hard stone, uh, laser, helium laser is better, I think.
You need to decide, before you start, because once you start, it's not that easy to switch, isn't it? In practice.
For infected stone, ultrasound is very suitable.
Ultrasound is good because this ultrasound has got suction as well. Is that correct?
Yeah,
So
yeah.
it will help to lower the pressure, especially in infected stone. It's beneficial to reduce the risk of sepsis.
Yes, yes.
What antibiotics did we give to this patient? Because this was an infected stone. What antibiotics? How did you treat this? How did you manage the antibiotics for this patient before you did the operation? Thank you, Professor Liu.
For infected stone,
For this case, because this patient has infected stone, so did you treat antibiotics for 1 week before you do the operation? How did you manage the infection for this patient?
oh, okay. If for infected stone, for very complex stone, uh, I will perform stage PCNL. Example, I will establish one thread to eliminate the pelvic stone and put the DJ stand for drainage. And after 1 month, I perform multiple threads to eliminate the residue stone.
Okay. And before you do the first operation, let's say this patient, how did you give the antibiotics before you did this operation? Did you treat the infection for 1 week and then you check again to see that the urine is negative, or did you just give antibiotics for 1 week and then you start the operation?
Yes. If for this case, the urine culture is positive, so I will use the sensitive antibiotics for 1 week. For 1 week.
Okay.
Uh, for our experience, we don't recheck the urine culture.
Again, yeah, I understand. Okay. I mean, in this case, sometimes you cannot clear the infection until you remove the stone, isn't it? Because the bacteria is hiding inside the stone, and the antibiotics you give can only treat the bacteria in the urine, but not inside the stone. So in this case, what antibiotics, Professor Liu, did you give this patient at induction?
Induction.
Induction, that means when the patient is asleep under general anesthetic and before you start the operation. Today, what antibiotics did you give this patient?
Pardon, what is reason?
Yeah, what antibiotics did you give this patient today?
Oh, today,
Yeah.
it's the same as the preoperative. The same.
Okay. Same, yeah? Okay. And then you will continue the antibiotics for how many days after this operation? So after this operation, how many days, will
Yes.
you give antibiotics?
If the patient post-operatively, if the patient low fever and the white uh, the white blood cell is normal, I will stop the antibiotics in the post-operative 1 day.
Okay.
Only use 1 to 2 days post-operatively.
All right. If the patient...
I want to ask you your question, Professor Simon.
Yes, Professor Liu.
If for the preoperative urine culture is positive, what is your strategy of antibiotics? How to use the antibiotics
Yeah.
for
So
your experience?
So in this particular case, we normally, will find out whether the patient is symptomatic or asymptomatic, and we would get the results back, like let's say 2 weeks before the operation, whether there is infection or not, and then find out the sensitivities of the antibiotic sensitivities. And sometimes we go even further back. For example, we get tertiary referral patients from another hospital. We would phone them up and chase the previous urine cultures, okay? Because this particular urine culture might only show one bacteria, but previous infections, there could be other bacteria inside this stone. So we need to chase the antibiotic sensitivities. That will be even better and even safer, okay? And then we would give antibiotic. If the patient is asymptomatic, we could start antibiotics 5 days before and continue on to the PCNL, okay? And then we would then, in such a case, especially if the patient has diabetes or any other risk, we would electively arrange for the patient to go to high dependency unit, stroke ITU, for observation for 1 night. And then there's no right, there's no wrong. I may continue the antibiotics for another 3 days. But despite all that, the patient can still get sepsis. Because you are releasing a lot of bacteria when you break the stone, and that's why suction is so important. In this case, you're sucking away the infected urine, the bacteria all the time. You're not allowing the system to distend, and you could potentially reduce the risk of sepsis. So that's what we will do. But the antibiotic prophylaxis, antibiotic treatment is highly variable and slightly controversial.
will you use oral antibiotics
Uh,
or
we,
use intravenous antibiotics
yeah.
preoperatively?
Preoperatively, it depends on the sensitivities of the antibiotics. For example, uh, ciprofloxacin, there's no difference between IV and oral, so it doesn't matter, you know. And as long as you give it long enough, like 5 days or 7 days before, then you can give it orally if you have a suitable oral antibiotic sensitivity, you know. So we used to, let's say 20 years ago, we used to bring the patient in and give 3 days of IV antibiotics before we do a staghorn stone. But we've stopped doing that, and we found that there was no major difference, you know. But I know that many countries are still bringing the patient in and giving them IV antibiotics even 1 week before, you know. And I think my friend at UCLH, he's the chairman of the infection section of EAU. He is doing a randomized control trial because he also knows that within Europe there's a big variation. Some people are giving IV antibiotics for 1 week before, and he's trying to cut down on the antibiotics, okay, to show that there's no difference.
Yeah, thank you. For preoperative urine culture, positive urine culture, normally in Thailand, I will use the IV antibiotics, intravenous antibiotics. I seldom use the oral antibiotics because the bacteria sometimes low sensitive oral antibiotics.
Yeah, I know that many hospitals are still doing that. They are giving intravenous antibiotics for 3 days or 7 days before doing a staghorn stone, an infected staghorn stone. I do know that some hospitals are still doing that, but then some hospitals that are not doing that, let's say they are not they used to do it, but they are no longer doing it anymore. They have not found a big difference. So they have not found any severe adverse sepsis or problems if they give oral rather than IV antibiotics. But we need more data. We need more data to decide if IV antibiotics is better than oral antibiotics.
Okay, thank you, Simon, Professor.
Thank you, Professor Liu. Yeah. Yeah, so that's a very good question. So mini PCNL means if you use a tract size of 22 or smaller, yeah? And so Professor Cheng's um mentor, boss before Professor Cheng, he went to America and then he learned standard PCNL. But when he came back to China, he adapted it for the Chinese people and he used 18 French sheath. And it's basically a non-suction 18 French mini PCNL. Exactly like what you're seeing now. So it's fantastic to be able to see this 18 French non-suction PCNL, and that became the Chinese PCNL. But in those days, when he did the 18 French mini PCNL, non-suction, excellent results, you know, smaller tract and all that. But in those days, publications from China were quite rare. So for a long time, didn't publish anything until he got to about 10,000 cases or something like that, you know. But then that was like 10 years later. So that's why there was no record of the Chinese mini PCNL being done in 1984, which was actually very early, you know, very early. So So, we publish an IAU paper that mentions that when you want to talk about any PCNL nowadays, when you want to talk about it in a conference, when you go to present in a conference, when you want to clarify that in a publication, it is very important to make sure people understand what kind of PCNL. If you just mention that you're doing a mini PCNL, there are so many types of mini PCNL now. There's a 22 French, there's 18 French, there's 14 French Super Mini by Professor Chung. Then now he's got an E SMP 18 French. There's Ultra Mini 13 French. There is micro PCNL 4.85 French. There's micro mini 8.5 French. There's suction, there's no non-suction. So in our IAU consensus paper, we specify when you want to talk in conference, when you want to write a paper, there's certain things that you need to clarify, like the name of the PCNL. If you say Super Mini, people more or less, some people will know. And then you clarify further 14 French, you clarify further suction, and then there are a few other things, in terms of description and in terms of outcome, you must mention in your paper, so that because there are earlier papers, people just say, no, I did 45 mini PCNL. No one knows what you're saying, Yeah. Yeah. Thanks.
And the Chinese mini PCN also is facial dilatation, and they're using a peelable sheet.
Peel away sheet.
Peel away sheet. Peel away sheet.
The peel away sheet was what the first mini PCNL started, mainly for children, isn't it? It was a 10 French peel away sheet that when people wanted to treat children, two-year-old child with a stone, that's how mini PCNL started, because they were looking for a way to treat a very young child, and it was started with a 10 French peel away sheath, and then gradually lots of modifications came along, So it looks like you're doing very well there, Professor Liu.
Yeah, this is the renal pelvic stone.
Yeah, and we can see your ureteric catheter nicely.
Yeah, this is the ureter catheter. So from the upper pole canis, just as we climb to the top of the hill.
So I see that your suction is quite strong, isn't it? Your suction is quite strong. You don't have much space to work on the stone, but you are trying to reduce the pressure. Nice. So I think you, Professor Liu.
Yes.
I think you have failed in your operation.
Pardon?
You have failed in your operation, because you're not showing us a multi-track, right?
Yeah.
You've done too well. You've done too well. You don't need a multi-track.
Thank you. Thank you.
But let's see, when we finish, let's see whether we've got the interpole ones, those are a bit parallel, and see whether we can actually talk all the way down into the lower pole. We can see PUJ separately now, which is good.
Professor Simon?
Yes, Professor Liu?
Is the compressed stone the patient in UK?
Yeah.
It is often be treated
Often
for compressed stone?
Often what? Sorry, do what?
Do you have many complex stone patients
Yes, we
in
do.
UK?
We do. We do. Because we do.
Oh,
Yes, we do. And we will make sure that we get, no, especially if they're older, they got comorbidities, diabetes, other problems, multiple sclerosis, paralyzed patient, bedbound patients. We will, get them heart problems on anticoagulation. We will get them to see the consultant anesthetist, number one. Number two, we will book an ITU bed for them to be observed overnight. And number three, we will be a bit more cautious to decide whether we want to clear all the stones in one go or whether we want to stage the operation and come back and do a second stage. So we do a regular safety planning meeting every week to discuss our patients that are about to have the operation in the next 2 to 3 weeks.
oh.
Professor Liu, I want to
Yes.
ask, today you are using Hamu Shenzhen, the aircraft carrier. And
Yeah.
in China, you are famous for doing multiple tract PCNL. And I heard that you have the score for doing 13 tract for one kidney. First, I congratulate you. I want to ask the scope you are using today, the Hamu Shenzhen you invented, and Professor Chen, we are eager to know more about this scope. You know, as junior urologists, we don't need to buy any more for different scopes to do BCNL. We can buy only one scope for different kinds of surgery. So tell us more about the working channel of this scope, how much the working channel, how many different kinds of energy we can use for this scope. Thank you, sir.
Okay. Thank you very much. Uh, exactly. You only buy one multiple functional laparoscope. You can perform standard PCNL, mini PCNL, and super mini PCNL. For this uh, 17 French laparoscope, the working channel is 3.8 millimeter, 3.8. And the laparoscope of Wolf laparoscope, the working channel is 3.5 millimeter. So the outer diameter is 17 French, but the working channel is larger than Wolf laparoscope.
So with that, can you put a combined lithotripsy, ultrasound and lithoclass through the 17 French nephroscope?
You want to watch the result of the combined ultrasound and the little class?
Yeah, because you mentioned
Okay.
that
Okay,
that
I'll show you.
yeah.
I show you. 把那个超声联合弹道。Okay. This is the ultrasound.
Yes.
Pro.
Yeah.
Okay, I take out the suction tube. And then take out this tube.
Yeah.
And change this connector.
Yeah.
This connector.
Yes.
This connector is for
yeah,
combine.
Yeah.
Combine. And
That's
then
for the lithoclass. Yeah.
那个小杆。
So this EMS ultrasound probe is how big? Nice.
Ultrasound is the same. 这个是这个杆多粗 这个哦，这个
I believe there are two sizes, right? There are two sizes, and the one you're using is the
就这个
bigger one.
The ultrasound pro is 9.9 francs,
Ah, very good. Okay.
and the little class is 0. Millimeter.
Mm. That's very nice.
And
So-
then the little class,
Yeah. Yeah.
so this is a button
Yeah.
to adjust the
The depth of the little class.
yeah. The relation of the ultrasound pro and the little class pro.
Can I ask you, because there was at least one paper to show that when you use the combined ultrasound and little class, the operation is faster by 50%. Do you believe that's true or not?
Sometimes.
Sometimes, yeah?
Sometimes.
Okay, yeah.
For most cases, I seldom use the combined liver filter. If for hard stone, I will use the little class and then use the ultrasound, not
Aye.
together.
Can you explain why you do that rather than combine right from the start?
Because for the combined liver filter, the space of ultrasound pro is smaller.
Yes.
好似擰唔喐嘅佢，壞鬼咗，佢哋綁個沙塊，綁咗佢。
It is. Yeah, this is Swiss Little Class Master. This is one that we have, and it's ultrasound plus the little class. You know.
OK，
Yeah, the trilogy is newer.
嗱拿着，
They claim that it's better, but it's so big and heavy. There is, yeah, the ultrasound comes with a suction. So this one, if you press the pedal halfway, it's only ultrasound. If you press the pedal all the way down, it's ultrasound plus suction. And then there's another pedal, the two pedals. The other pedal is the little class. So you put your foot down on both pedals all the way down. Three things happen: the ultrasound, the suction, and the little class. Yeah. Thank you so much for showing us and setting up so quickly, because setting this up can be a bit tedious.
You must touch two pedals.
Yeah.
But for the 6th generation EMS, you only touch one pedal.
That's the
Have you used the
trilogy. That's a newer one called
6th
trilogy.
generation EMS?
Yeah. Yeah. It's very heavy, the trilogy, very heavy. And sometimes it's easier to bend the probe because it's too heavy. So unless you move your trilogy and your nephroscope together, you know. But
Do
if
you think
don't-
combined is better?
Well, I'm learning from you because we always use combined. We always set up our hours as combined.
For
So,
this case, maybe combined is better.
well, you showed that it's done very, very well with just the ultrasound. So I need to learn and maybe change my practice.
Yeah. Now you can hear the sound of the ultrasound and the little class.
Yeah. But I have to say that currently, um, so in this case, I would have done a 16 French Super Mini with laser. So I wouldn't. So it's not common nowadays that I use the little class. Maybe 5% of my cases. That's down the ureter, isn't it? Yeah. Yeah.
For this combination, if you reduce the broken.
So sometimes we will pull the ureteric catheter below the stone and then flush from below, and then together with your suction ultrasound, it'll be very effective. So yeah, I've tried it. Yeah, so it's okay. It's quite nice. Have you tried it?
Yeah, I mean, for my center, we have that particular system as our main modality, and based on our personal experience, that I mean, in terms of the efficiency, it's good.
Yeah, it's supposed to be
Yes.
one of the best at the moment. You know.
Yeah.
Yeah. Any difficulty handling it?
I think in terms of the head, I think it's lighter, definitely lighter. compared
Lighter
to
than
the EMS trilogy.
the EMS
Then you
trilogy.
can control the degree of the suction itself, depending on the
帮我打点水上来啊，
So you can really fine tune.
就是把那个板往下抽一点。
Yeah, the short pulse. Yeah.
Short pulse, yeah.
就往下抽一下，对，
And do you
往
use it
往
all
下
the
拉，
time? Do you use it all the time?
Yes, I think even for hard stones, I think
Yeah, 往下抽。
it fragments it and sucks it very well.
Yeah.
打水上。
I would use everything combined together.
Everything
Isn't it?
combined
Yeah,
together.
yeah.
对，yes yes。
The industry, which industry? The EMS. Yeah, 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 yeah. But some manufacturers, they tell you that after, I don't know, 10 users or whatever, you have to change the probe.
可能要攞個激光過嚟，因為我哋要。
I did, yeah, and it's expensive, So not every country can want to spend that kind of money. They can save that money for other things. So there are other ways around it as well, that you don't use
可以
those
等一下再打，等一下再
expensive
打。
process.
You only have 5% of New Zealand
Yeah.
for a very rich country. That is the trend already, the suction. And even like a country, the Philippines, it's not that rich country. A suction sheet is a blessing to us because mostly we are using the pneumatic.
For this case, maybe combine is better.
Well, pros and cons, because without the little class, then you can suck out those fragments more easily. But now you got the little class blocking the way, isn't it?
Yes.
And also, it's quite difficult to drill small fragments like that. And so there are pros and cons.
Thank you for your good opinion.
No, you're doing a great job. Fantastic. So good that you don't need a multi-tract.
We only decide the differential tool only according the CD scan, the hardness. It is not. It's not.
That looks like the lower pole, isn't it? So you've actually got to the bottom of the kidney already. That's fantastic. Yeah. But then you got some interpole stones that you may have to turn the corner to get them. Like that, yeah.
According to your opinion, how to choose the differential tool?
Okay. So I don't have a problem like that because 95% of my PCNLs are sort of super mini, either 14 or 16. So I use thulium fiber laser to dust the stone and suck the dust out. It's only in a very, very complex case that I will do 24 French PCNL with the
喂，聖
EMS.
哥有冇塞啊？
Yeah. So in a case like this type of
聖哥我就
staghorn
唔係好
is
掂。
not considered complex. I would do a size 16 or size 14 super mini PCNL.
翻嘅間咧，咪點鬼咗？翻嘅間，嘿，可能鬆咗你睇。
You think which one is faster in terms of speed of completion?
Yeah, so I think if you use a size 24 with an EMS combined, I think it's faster, you know. But now there is a trial underway to this. No, remember Professor Cheng's publication in European Urology comparing 24 and 18,
翻啦嘛？
but 18 was non-suction
誒
and
太陽，太
the
陽，
18
鬆嘅啫嘛，應該。
equal stone-free rate, less complication, but slightly slower. But now Professor Cheng is
Oh,
going to
sorry.
do 24 versus 18 with suction to see whether it's going to be
Okay.
faster or not. So we will
Xong
know soon.
If you're doing regular discussion, right?
Yeah.
For the combined liver treater, you also only use ultrasound or only use little class?
No, at the moment I'm using always combined. So
Oh,
when we decide that we want to do a 24 French, let's say PCNL with Swiss Little Class Master EMS, we always assemble the both components together, always.
Oh,
But I'm learning that maybe for very soft stones, maybe just ultrasound without the little class is also another option. But some people believe that if you use combined, it may be a bit faster as well. But like you said, it's case by case basis. Different stones respond to different modalities, you know.
most of the, you use the combined.
We do. We always assemble both together, you know.
Oh, thank you.
But now I'm learning. So maybe I might do a bit more ultrasound only. But we don't have many soft stones. That's the problem. And if it's soft, then we'll do super mini.
Ask it.
Is that the ureter? Yeah.
Yeah.
So could someone help you to flush saline from below? You are doing it. Yeah, yeah. Okay. Well done. Fantastic.
Only
Nice. Yeah, these kind of stone fragments are neither here nor there. They're very irritating. They they're slightly too big to be sucked out, and yet just have to be patient.
very fast.
You are very fast. So, Professor Liu, because I've had the privilege of coming into your theater before, I know that you got everything. You got ultrasound, X-ray, EMS, super mini, everything. Do you have any advice you want to give to the people in the audience? You know, when they want to set up, when they become their own boss, when they become, when they want to build up the stone unit, how should they set up for PCNL? Would you say they should always have a low power holmium laser machine?
If I low volume laser,
Yeah, low power laser. Do
low
you
power laser.
do you advise everyone to have a low power holmium laser machine, or do you believe that a high power laser machine is even better,
Oh, I see.
or no difference?
I see. I think if I will choose the high power volume
Okay.
because for some very hard stone, I will use the 80 watts, the maximum power 80 watts.
Yeah, yeah, 80 watts. So in your 80 watts, how do you, what kind of frequency hertz do you use for your 80 watts?
How to
Do you,
avoid the heat injury?
no, how do
No.
you, what is your setting for your frequency? Is it 80 hertz? When
Uh,
you,
2 joule to 40 hertz.
2 joules and 40 hertz. Okay, yeah. And when you say 80 watts, are you talking about PCNL, or are you talking about flexible ureterorhinoscopy?
Only for PCNL.
Only for PCNL. I agree.
Yeah,
I agree.
because the water flow must above 40 milliliter per minute.
Yeah. High irrigation, high
Yeah.
removal of heat and saline by good suction.
For 80 watts, I seldom use. I mostly use 40 watts
40
for
watts is your
PCNL. Yeah, yeah.
standard setting. Yeah. And in your 40 watts, how do you divide your frequency in
Setting.
your joules? Do you
Two
use two joules?
2 joule 20 hertz.
20 hertz. Okay. Yeah.
Uh,
And do you think that doing the EMS, ultrasound, or combine is faster than doing, let's say, an 80 watt holmium laser in this case?
In this case, I think EMS is better than the 18 French ESMP. I think
Because faster?
because the stone is suitable for ultrasound
Yes.
laboratory.
Yeah, yeah. So, so for example, between 18 French ESMP, 18 French ESMP with laser and suction, and 18 French Chinese mini PCNL with ultrasound probe, you still prefer the 18 French Chinese mini PCNL with the ultrasound?
Pardon. You say which is better for Chinese PCNL or
Or the,
ESMP?
yeah, the ESMP, yeah.
ESMP.
Yeah.
Maybe ESMC is better than the traditional Chinese PCNL.
Okay, okay.
Suction is very important.
Yeah.
From God.
Okay. For this test, I can see the upper pole, the renal pelvis, and and the lower pole.
Yeah. There are two branches like interpole calyces. No, on the X-ray you can see there are two branches to the interpole, to the mid pole. So there is a small chance that there could still be a fragment in the superior interpole calyx.
This is the upper pole. Oh.
Yeah. How about the interpole? The interpole. Can we try to check the interpole, please?
Can I check the interval?
Yeah. On the X-ray, you can see that there are two interpole calyces with stones, and
Yeah, I will check under the ultrasound and the X-ray guidance together.
yeah, because the upper one is almost parallel lie to your puncture, so and especially your infundibulum is narrow, so we'll see whether we can see the.
Okay. How use ultrasound?
Can we see the ultrasound pictures, please? Thank you.
For the lower pole, maybe
So,
there are residue stone here.
yeah.
For this stone, it is not very clear in under the ultrasound guidance. Not very clear. Maybe for the this type stone, the CT scan is not hard stone.
And there's one in the interpole as well, I think.
Yeah, 要將嗰個對比度調咗白啲咩？ For this case, maybe the second thread, it is difficult to use the ultrasound guidance, maybe.
Yeah, because once you've done an operation, that can be blood clots, can be gas, that make it more difficult. So in UK, we would pre-puncture. If we want to do multi-tract, we would pre-puncture, and the second tract would be coming through the interpole calyx.
You will.
We will put a guide wire down.
And
before
perform the
we start
second
yeah.
puncture.
Correct. Yeah.
How many threads will you have you performed in one cases?
4. Not as many as 9 as yours, so only 4.
Okay. I mostly use one by one to establish another thread.
Yeah, because you can do it so well. You don't see very much perinephric collection, because it's quite common to have perinephric collection around the kidney, gas inside the kidney.
我们看 X 光 X-ray。太热了，加点水了。
Yeah.
好 ，X 光。现在不好看的嘞。Oh, maybe only one.
If you have it, use it. If you don't have it, it's not the end of the world, Yeah.
你把它调黑点。
The stones were not very radial.
Oh.
Start off with, that's the problem.
不要太黑，亮回一点。But for this residue stone, it's not clear in under outer guidance.
Or X-ray, yeah, it's not clear.
also not clear in under X-ray guide.
I know. It was only when you put the contrast from below, when you put the contrast from below, it was very helpful. Can you try to put some contrast from the
Yeah, yeah, yeah.
catheter?
I will try. I will try. But sometimes the contrast will influence the puncture.
Yeah, yeah.
放个小镜子，放个小镜子，小跳。Now I take the mini laparoscope because the stone is small, so I will take the laparoscope for mini PCNL.
Okay.
你要旋轉球管喎，俾我。好，嚟，方先生 ，difficult case。18就行。哇，这个很难啊，这个。冇用金屬。
You make it look so easy.
Oh, not clear.
Yeah, this case is quite unusual, isn't it? That the stones are not very radio opaque.
Maybe I inject some contrast. But it is hard to identify whether it's cross and whether it's for contrast.
At the moment, we suspect that there could be a small fragment in the lower pole and maybe a fragment in the interpole. And the others we can assume may be clot. But there were not a lot of clots when you finish, you know? It was quite clear. So are you thinking of putting contrast from below or through your puncture?
一打照相机都看不见。係啦，比較難。誒，這個是很清楚咯。很不清楚是吧？这主要很不清楚。Oh, oh,
Oh, perfect.
very small.
Yeah,
calyx.
interpole calyx, the one that I thought might be a stone, but with a very narrow infundibulum. So no way will you get this from the upper pole puncture. It needs a second tract. So amazing.
It's very parallel to the
Parallel to where you went in. Narrow, tiny infundibulum. So,
For me, very, very difficult cases for me.
well, it was.
Oh.
Don't know how you managed to get in. You could hardly see the stone.
The guy why come out the collecting system? Guy why?
Because there is not much space between the stone and the urothelium, you know. You're in the right place because your contrast was perfect, but there is not much space between the stone and the tight urothelium. So it's very easy for the guide wire to go in and come out, bounce onto the stone and come out of the, but your access is very good.
Hả? Cái con
Professor Liu, are you using now the SMP for this second track?
I will use the I do not use SMP because it will waste some time. So I use the 16 branch.
Okay.
没有18的吗？哦，没有16的，只有一根的。算了算了，18 branch。
Amazing, isn't it? Your tip is in, but your guide wire is out. Be careful with that. You can do it, but for starting, don't do it. You might overshoot, bleeding will work.
Cái水泵可以大啲喎。
Sometimes you know you're in, right? You're leader. But when you pass the guide wire, that
Oh, can you see the stone?
I saw it. I saw the
Hey.
yellow stone flush.
The guide wire is come out the collecting system. You
Yeah,
see?
but the stone is right in the right place. You're in the right calyx, and that was challenging. Yeah, very good. We're all impressed by your puncture. Very nice.
Because the stone is it's not clear under the ultrasound and the X-ray guidance.
Yes.
So for me, it is difficult cases.
Difficult case, but you made it. You make the operation look so easy.
地方打着。
No, this is 18. This is 18, because don't want to change the nephroscope, change every system. It's easy. Yeah.
But this stone is suitable for SMP, but for SMP it will waste some
Setting up a
sometime.
new suctions, everything new, and yeah,
Yeah.
a second system. So are you using laser now?
Yeah, laser.
Okay. Professor Liu, there's a question from the audience. What is your laser setting now?
2
2 joules?
20 hertz.
20 hertz, 40 watts. Yeah. Do
This
you?
brand is Chinese mini PCNL, not ESMP, not SMP.
Yes. Do you normally turn on the aiming beam, or do you don't like to turn on the aiming beam for your laser?
Oh, for stone surgery, I seldom use the aiming beam. But
Okay.
if for HOLAP, I will use the aiming beam.
Okay.
So do you use the aiming beam normally?
Yes, we do. We do. Yeah.
This is a good habit.
I think when you are super experienced, you can get away with anything. Everything you do is right, but for the younger ones, they need to know the alternatives. Yeah.
Professor Liu,
Yes.
in you, we can't X-ray, but you made it. We see now
Pardon?
What flow?
Use you push water a couple of times before you push the contrast. So what is the secret behind this technique? I've seen a lot of times using this technique. You're using this technique.
You say before inject the contrast, I inject some saline.
Yeah.
Yeah, this is very important. Uh, if you cannot confirm the needle whether enter the collecting system, you should not inject the contrast.
And when you injected the saline, does that give you information about whether you are in the calyx or not in the calyx?
Yeah. The pressure is different. If the needle is in the collecting system, the pressure is lower. If the needle is outside the collecting system, the pressure is large.
So when you insert the saline, I saw either 5 or 10 mils, you could feel that the saline is going into the collecting system. Is that correct?
Yes.
Good question, good tip. Excellent tip. Otherwise, the
On-
contrast will go everywhere, and then it would guarantee a failure, and you have to stop, you know?
Yeah, only one small stone. And in particular of this candidates is narrow.
Narrow. But
So
there
it's
could be a,
difficult to combine RIS to eliminate this stone.
but there could be a stone in the lower pole as well. Are you
Maybe.
in the pelvis now?
Maybe. So I check the X-ray again.
Yeah.
Okay.
Maybe a third tract, unless you go into the lower pole with your flexible ureteroscope.
走吧，真的很难，这个看不见。
I think it's multiple tract. Yes, yeah. Multiple tract.
哎，我那里还有一个。Can you see the residue stone?
We can see a few shadows. We're not sure which
Yeah,
one is
yeah,
the
yeah, yeah.
stone.
Very difficult case.
Yes.
Okay.
Wow. Third puncture.
You make sure you get what you paid for.
Amazing. Amazing.
Make right when the contracted when the first part when the collecting system contracted
咦，
to then the very back
这么浅？
in each in each height.
Professor, I have a question. Is it a must to dilate the narrow infundibulum?
I don't think this one was actually a calyceal diverticulum. It's just a narrow one, that's all, but it's not so narrow that you have to dilate it. Yeah, it's not exactly a calyceal diverticulum, you know. I think it's just a natural variation, a natural slightly narrow infundibulum, but it's not abnormally narrow. Yeah.
So you don't have to dilate it.
In this case, no. No.
But for other cases, Professor, if it's abnormally narrow, it would be beneficial to dilate it for to.
Only if you think that it's a calyceal diverticulum, that
Yeah.
because of the
好似唔
narrow
係啊。
infundibulum, the calyx has become
誒，呢個係
dilated.
Yes.
So in this case, it wasn't abnormally dilated, and it's not sufficiently narrow. I think once you remove the stone, it will be back to normal again.
OK。喂，
It's
16 好
a
啦，大佬。
variation of normal. Now you see this again, flushing of the. Yeah, there's a bit more resistance or not? I'm not so sure.
Oh.
Contrast.
屌， Go.
Wow, fantastic.
Bình lượng đó mày. Ý điểm.
这个是最后一台了，也是差不多，我知道，差不多要结束了。如果太久的话，我们可以差不多要结束了。
Do you think this is the last residue stone?
I think so. Do you check with a flexible nephroscope or flexible ureteroscope at the end of your operation normally or not?
I seldom use.
Seldom. Okay.
I seldom use because there are some bleeding. It is difficult to find the residue stone.
Yes.
Maybe for second stage PCNL, I will use the flexible linoscope.
Yeah. So X-ray gives you the depth of how far you push. You see, it's useful.
Oh.
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 Yes.
More. Oh.
Isn't that the lower pole stone?
Yeah. No problem.
Well done. So can we flush saline from below or not necessary? Oh, laser. Okay. But laser, but no suction.
No suction.
No suction. Any flushing of saline from below may help or not? So the vortex works well.
If you use the suction, it will waste a little time.
Mm. Before, yeah? Yeah, I remember. Then like this case, you can also do PCIRS. So if the legs are split, you can always put a scope up as well.
你帮我装那个超声杆，
Kidney injury.
把超声杆装上，纯超声。我最后把那个血块啊，给它吸一下。
No, use ultrasound second. In this case, what is your exit strategy, Professor Liu? Are you going to put a stent in, or are you going to put one nephrostomy in, or
Okay.
nothing?
Thank you. Because for this case, I will place 1 to 2 small size laparoscopic tube. For this case, the 20 French thread, I only place one 14 French laparoscopic tube because the tube is larger and the number of the tube is large. The more the tube, the patient will feel more pain.
Yes. So,
So I will use the small core tube
yeah,
or tuberous.
yeah. So
Partial tuberous.
in this case, you are thinking about putting maybe 2 nephrostomy tubes in, right?
Yeah, one to two.
And then what will happen after that to the patient? When will you take the nephrostomy tube out? How long will the patient stay in the hospital?
Yes. If tomorrow, if no bleeding, I will remove the tube.
Okay. Both of them, yeah? And
So
when,
I check this tube. Yeah, low bleeding
yeah,
and check this.
you clamp the tube first, yeah? Okay. And then take out the nephrostomy tube maybe tomorrow as well?
Yeah. So last, I will change the 17 French laparoscope
Yeah.
to use the ultrasound probe to eliminate the block.
Good. So in the practice in China, um, uh, do you prefer to put nephrostomy tubes in rather than putting double DJ stent in?
Yeah. In China, most patients will place double J stent. Why? Because most Chinese urologists only use ultrasound guidance for puncture. So it is difficult to identify whether there is residual stone or not. Only using ultrasound guidance. So
Yes.
they will normally place DJ stent. If there is residue stone, they will use ESW to treat the residue stone. So for many Chinese urologists, they will place the double J stent.
Okay. And I see that you are using your nephroscope and checking different
声音很小，我听不到。
So now I see that you are using your nephroscope and you're going into each and every single tract to check for residual stones. Is that correct? And to suck
Yes.
out the any blood clots. So I don't see any advantage in putting 2 versus 1 nephrostomy tube. I would have thought in this case only 1 nephrostomy tube is more than enough. Do you
Pardon?
agree?
Pardon?
Yeah, I was thinking that only 1 nephrostomy tube would be enough and don't have to put 2. Why are you thinking about putting 2? And what are the advantages of putting a second nephrostomy tube?
Yes. If only for drainage, 1 laparoscopic tube is enough. But sometimes, if there are some bleeding in more than 1 tract, I will place more tube.
Yeah, I see the rationale. Do you believe that nephrostomy tube will tamponade the tract and stop the bleeding? Some people don't believe that the nephrostomy tube makes very much difference in terms of stopping the bleeding. Some people believe that the nephrostomy tube can help to stop the bleeding. What do you think?
Yes, thank you. The laparoscopic tube mostly is for drainage, but I think it is difficult to the tube. I think it cannot stop artery bleeding.
Yeah.
But maybe for venous bleeding, it's okay.
Okay. Okay. Thank you. Yeah. Okay.
You can see that the small residue stone will be in the block.
Not much, isn't it?
To Professor Wu and Professor Priu. No, he has to go early.
Just find place.
So if you use needle class, this procedure is difficult to perform.
Looking good, Professor Liu.
Yeah. I also praise DJ double J. Then
One double J and one nephrostomy tube.
yeah. Yes.
Why do you want to put a DJ stent?
Only for SMP I will perform total tubeless
Yeah,
PCNL.
I understand.
For the other type PCNL, I will only use partial tubeless PCNL.
Yes.
Will I very worry about because of the ureter edema,
Yeah.
the small residue stone will block the ureter.
Yes. Yes. In this case, if you put a DJ stent, do you still want to put a nephrostomy tube?
I think the laparoscope is more important than the double J stent.
It can drain better. Yes, I
Yeah,
agree. Yeah.
doing better.
Yeah. So when you take your nephrostomy tube out, because there's a coil in the kidney from the nephrostomy tube and there's a coil of the stent in the renal pelvis, do you have to screen it out under X-ray guidance? Because in case your nephrostomy tube pulls your stent out, or you don't?
I think under the X-ray guidance to check the tube, the side of the tube is important.
Okay, yeah, that's what we do also. If you have a nephrostomy tube in the renal pelvis and a stent in the renal pelvis, we screen it out under X-ray guidance.
X-ray to check again. Yeah. 对，这个要剪掉，这几个不剪掉影响这几个。Okay. Oh.
Very good. The stent is coiled in the lower pole.
啊，上面那个了，那个不是，上面那里还有没有？这个地方，不用移。 好像沒有了。咦，那過啦係唔係啊？嗰啲唔係嘅，就是那個肋骨重疊的那塊，是不是？你傾斜一下，就那個，就這樣傾斜一下，就咁樣斜一斜。對對對，哎對對對 ，OK， 走。好像是的哦。是不是移開了沒有？這邊呢？不確定。哦，不動的。哎，往後退一點。Okay. Now, can you see a shadow is covered with the 12 rib? But,
near the upper pole tract.
yeah, but for the dilated image,
Moved.
maybe it is the residue zone.
But we couldn't see it when we were inside.
打点照相机看，不是打照相机看不到了，好像有一个哦，给个针给我，针没了，针没了，这个是不是的？哎，前长给我。
Tried that before. Single incision, multiple cluster. Single incision.
Oh.
So
Why?
Me-
You can do it without it. And how is
不是很像啊。但不是很像。嗯，的确是在里面哦。这跟刚才那个有什么不同啊？哦哦哦哦哦，是不是有个通灵确诊？老师，可能不是，我太太还没信呢，不知道是不是的。可能不一定是。哦哦哦哦哦。咦？哦
Wow.
哦
Found it. Amazing.
，yes，钳子
So
，forceps
deep.
exactly。 Oh, very
If you
small.
can grab some lunch over if you want.
Oh.
It's getting cold. Yeah.
Beautiful.
Oh.
Wow. Go toilet.
Oh.
The stone is there a little bigger.
Maybe. Thousand.
Yeah, it's too big to pull out.
Very large residue stone.
Do you think this is the last one, Professor Liu?
Do you think this is the last residue stone? So sometimes I will use this method to find the residue stone.
Mm-hmm. Professor Liu, for the benefits of the audience, how many multiple track have you done? How maximum tracks that you have done in a single kidney of a patient?
激光呢？打不动。激光提过来。这是那个。If low your encourage, I will not puncture this press. Okay.
Very nice.
Very nice. 拔掉。Oh, yes. 好 ，try again.
So how many nephrostomy tube you are going to insert?
One tube.
One only on the upper pole.
Yeah, on the upper pole. Maybe how to place the laparoscopic tube? Normally, for the if the thread in the upper pole or the thread is more near the abdominal,
Uh-huh.
I will place the tube because the upper pole it is easy to injury the thoracic
The area of the pleura.
yeah. Easy to happen pleural injury. But for the nearby the abdominal will be injury the column. 你唔走啊？走。Okay.
Congratulations.
I will place for 14 14 號嘅座碗14 French Leprous tube in the upper pole. Now I check the size. Use the contrast to check. So 數一下。 走走走，不用接，走，不用扶，不用扶，走。扶。Okay. Okay. Thank you very much. Thank you.
Thank you, thank you.
Professor Liu, well done. Fantastic job. Oh,
Thank
we
you.
learned so
If
much from you. Thank you so much, Professor Liu.
if you know your encourage, I will not perform the folded puncher. Thank you.
Well done.
Do you have lunch, Professor Simon?
We are about to have lunch. We hope you have a lunch, and we hope to see you later.
Okay. See you later. Thank you very
Thank you
much.
so much. Well done, Professor Liu.
鸡蛋糕。
打甲管，把那个拔掉。
Lab okay.
好了，把那个图像看掉嘛。对，工程师。